more than 100 nanogram. And the hepatic fibrosis, we already know this is hepatic fibrosis between the pathology and the surgical, the pathology. We can grading from the 0 to grading to the 4, or according to this method is grading 0 to the grading 6. And the degree of the liver fibrosis is very critical, very important in determining the post-surgery outcomes for patients with small HCC. So we, using this method, we compare the AST to platelet ratio index. We call it the APRI, can predict the IFA outcomes. So we can see if the APRI ratio is smaller than 1, the overall survival is better, and the recurrence rate is also better. And how about the splenic volume? Also, we can use the patient with splenomegaly had a poorer overall survival rate than those with normal splenic volume. So we, our definition is splenic volume is if splenic volume is larger than 300 cc, then we call it splenomegaly. And we using the computing method to calculate the splenic volume. So the HCC patients with splenomegaly measured by CT scan have a relatively poor liver function reserve than those with normal splenic volume. So the splenomegaly larger than 300 cc is a very important risk factor predicting the overall survival patient. And the age, we found that the younger patient had better prognosis than the older patient after the IFA. And how about the vascular invasion? We know after the multivariate analysis, the microscopic portal vein invasion is the only factor that had a significant effect on patient survival. So in the end, I will just briefly introduce how to enhance the effect of the local operation. Actually, there are many methods we can use, and we can hear many different speeches in the following 2 days. So I just only briefly introduce the real-time virtual sonography and the ultrasound contrast agent. And also we're using the elastography and the AFI, acoustic radiation force impulse image, to predict the effect of IFA. So this is using the microwave for the HCC patient. We can see this tumor nodule is just between the right portal vein and the right hepatic vein. And from the coronal view, we can see almost 1/3 of the liver tumor is abutting the right hepatic vein. So usually if we're using IFA alone, sometimes maybe have the hissing effect. But if in this case we're using the microwave, and we can see the total necrosis of this tumor, and the tumor area is shrinkage after the 6 months, and this is a 6 months CT follow image. And also we can use in the microwave to treat the larger tumor. So such as this tumor, we're using 3 antenna to treat the tumor. This is the on-site monitor of the ultrasound. And in the real-time virtual sonography and the ultrasound contrast agent, nowadays we're using this to enhance the effect of the IFA. So such as this tumor, we can find that it's just only about 1 centimeter in size. And the enhanced pattern is not very obvious, even in the arterial phase and in the portal phase. You can see that this area is not enhanced. But if we're using the ultrasound contrast agent and the real-time virtual sonography, we can see the tumor is very clearly. And in another patient, this patient has received surgical resection and also the IFA for the first-time treatment. But after first-time treatment, there is still a little valve tumor here. Sometimes in the ultrasound alone, if we want to treat this area, maybe have some difficulty. But we're using real-time ultrasonography and ultrasound contrast agent, and we can see how it works. After the ultrasound contrast agent injection, this is about 25 seconds, and we can see the ultrasound contrast agent into the vessel, then to the tumor area. You can see the tumor is here, and this is the portal vein. So it's very clearly. So then we can put a needle or the antenna to this area to treat the tumor. And finally, we can use this method to perform some quantitative analysis. This is the tumor area, is the yellow line, and this is the background, the normal liver tissue area, and the red line is the main portal vein curve. So it's different, and we can do some quantitative analysis. Okay, so in the end, I just want to briefly say, because I know other speakers will speak about the RF and the elastography in predicting of the RFA. So today my speech is the exciting development in ablation technology. So all effective when used properly. So we must, every doctor must know your system. And the operator skills still very important. We must be familiar with ultrasound, CT, or even the MR target skills. And also it's important for the patient selection. And in BCLC very early stage, we propose the IFA is not inferior to the surgical resection in overall survival or in the recurrence rate. And the switch controller IFA or the microwave may be very effective in the small to medium-sized neoplasm. And when we're using the ultrasound contrast agent with real-time ultrasonography, it can enhance the effect of the treatment of the liver tumor. So again, thanks everyone to Taipei, and we hope you enjoy this 2 days trip in Taipei. Thanks everyone.
Thank you. Professor Minami, Yasunori Minami from Japan, and I know him very well. He is a student of very famous Japanese hepatologist, Professor Kudo, and he worked his department, and he started his career about ultrasound and fusion image, and but nowadays he also covered the other Kobe Central Hospital, and he also practiced intraarterial therapy by himself. And he is a very active, the younger professor in Japan. So why don't you start your talk? Professor Minami, please.
Good morning, everyone. Thank you for giving me the opportunity to present here ACTS 2014. My name is Yasunori Minami. Came from Kinki University, Osaka, Japan. I'm a gastroenterologist and a hepatologist. I have no COI to disclosure. This is a table of the local contractility of RFA. In many papers, mean tumor size is more than 2 centimeters. It is reported that, It is reported that the local recurrence rate range is from 1.7 to 41%. This is a mechanism of local recurrences. A microsatellite and vascular invasion often occur with HCC more than 2 centimeters. If poor ablation margin, local recurrences are likely to occur. On the other hand, microsatellite and vascular invasion are rare in smaller HCC, and then complete ablation can be achieved by RFA. This is the gross classification and the malignancy grade of HCC. The progress of gross classification from single nodular type to single nodular with extra tumor growth and confluent multinodular portal invasion and intrahepatic metastasis are likely to occur on pathology. We reported that the consonant enhanced US using Sonazoid are reliable tool to evaluate the gross classification of HCC. So, according to the tumor site, tumor location, growth type of HCC, we should consider the indication for RFA. Whenever I instruct our young doctors on how to do RFA, show wide clear view on US and keep the inserting needle tip in view of screen for self RFA therapy. And for good local controllability of RFA, you need wider safety margin. Wider safety margin is produced by precise needle placement. So, how should we do RFA of HCC that cannot be detected on US because of pulmonary error? Artificial pleural effusion can right lung rise up, and after that, acoustic window and pathway to the liver are obtained, and RFA could be performed. After treatment, it is often difficult to detect local recurrences of HCC on B-mode US. How should we do RFA of local recurrences that cannot be detected on US? Fusion imaging guidance in RFA is one method. RFA guided by fusion imaging is efficient treatment for HCC poorly defined on B-mode US. Contrast enhanced US guidance in RFA is another method. Contrast enhanced US using Sonazoid can show tumor stain in the vascular phase and defect in the post-vascular phase. Contrast enhanced US can provide guidance in RFA. So, can the combination therapy test plus RFA provide better survival than RFA alone in HCC patients? According to two papers, RFA combined with test is more effective than the RFA alone for extending the ablated area. You can see the three papers comparing the survival between test plus RFA and RFA alone. Just only Dr. Peng reported that test plus RFA could result in the better survival than RFA. But the other paper not. I think this is still a controversial issue. So from this slide, the second half we start. What is the condition of RFA for HCC? Of course, RFA usually performed early stage HCC patients with good liver function. So there are several guidelines for HCC, ASLD, ISO, APASO, two guidelines in Japan. You can see the very early stage and early stage of BCLC staging. And the Milan criteria is arranged by red frame. According to ASLD ISO guideline, very early stage HCC patient without portal hypertension is applied to surgical resection. The other within the Milan criteria, liver transplantation first, ablation second. This is a personal guideline. Within Milan criteria, resection is first choice if resectable. Local evaluation is applied to unresectable patients. According to Japanese consensus-based guideline, ablation is first choice, and local ablation is applied to unresectable HCC patient. So, which is better treatment for RH stage HCC, RFA, or surgical resection? This is very hot topic. This slide shows the time trend of manuscripts. Total 40 manuscripts comparing the survival between RFA and surgical resection could be hit after 2006. This major manuscripts is listed, including 2 RCTs and a large cohort studies. In half of manuscripts, there are no significant differences in survival. On the other manuscript, surgical resection could provide better survival. Again, which is a better treatment for early stage HCC, RFA, or surgical resection? RCT can answer this clinical question. I would introduce 2 RCTs. This is first RCT reported by Dr. Chen et al. In 2006. According to their results, there are no significant differences in overall survival and disease-free survival. However, major complications often happened significantly more often after surgical resection. In summary, there was no significant difference in efficacy. However, RFA was safe and less invasive than surgical resection. This is second RCT reported by Dr. Hang et al. In 2010. According to their results, surgical resection could provide better survival, and surgical resection could provide lower recurrence rates than RFA. However, major complication and long hospital stay happened significantly more often after surgical resection. In summary, surgical resection could provide better in efficacy, but RFA was safe and less invasive than surgical resection. Again, which is a better treatment for early stage HCC, RFA, or surgical resection? Now, still controversial. Okay, now going trial in Japan named SURF. The SURF study is a multi-center randomized control trial within 3-3 rule HCC. In this study, total sample size was designed as 300 cases. Now, total 261 cases have been registered. We expected that the SURF trial can provide more robust evidence. Local ablation therapy is a treatment of choice for early stage HCC. For safety, RFA therapy need show wide clear view on US and keep the inserting needle tip in view of screen. For good control, local controllability of RFA, wider safety margin is needed. Wider safety margin is produced by precious needle placement. RFA may have the potential as a competitor to surgical resection because of the advantage of less invasiveness. This is last slide. Fourth International Kyoto Liver Cancer Symposium, ICLS, will be open on 7 to 8 June in Kyoto. This topic of the conference is emerging strategy to HCC, in particular the molecular targeted therapy. We are looking forward to meeting in Kyoto, and let's discuss HCC. Exciting. Thank you.
It's my great honor to present this first Asian conference on tumor ablation. So today's my topic is how to increase the ablation size. So I think the factors related to the ablation size, the type of electrode, there are various type of electrode, single, multiple cluster, or internal cooled versus perfused or multi-teamed. The other one is monopolar versus bipolar. So these various type of electrodes can make the different size of RF ablation. And another one is RF ablation technique with overlapping technique or combined ablation with the TACE or combined ablation with thermosensitive liposomal drug. So I will briefly review of the reported articles about these factors and then summarize. The simultaneous RF application to a cluster of 3 closely spaced internally cooled electrodes enable a very large ablation zone. This cluster electrode has the 2.5 centimeters positive, and the minimum and maximum volume of diameter is about 4 to 5 centimeters. This is 1 or 1.5 centimeter larger than the as compared to the single coated RF ablation. And in 2006, this article reported the multiple electrode RF ablation system enabled the much larger creation of a significantly larger ablation zone in vivo animal study. So you can see this figure is about 2 cm diameter ablation zone with the single electrode. This is about 2.8 to 3.6 size of ablation zone made by clustered electrode. This large size of ablation zone measuring about 4 to 4.7 size ablation zone with 2 cm interdistance electrode distance in the multiple electrode RF ablation. And 2007, this article reported that a multiple electrode switching generator is technically feasible and safe and generate a large ablation volume. So this is very widely and very popular in worldwide. Quiddian's RF generator with the switching controller. So this report showed that 2 or 3 electrodes can make the mean maximum ablation size is more than 5 centimeters. So the post-immediate RF ablation CT image shows very large low-density ablation zone, completely replacing the about 3 cm size the index tumor. This is another reported multiple electrode switching system with the other company, and this report in small and medium-sized HCC was safe and efficient, and this generator make a very large ablation zone. So this large ablation zone may contribute to the low local tumor progression rate about 11% at 3 years for small and medium-sized HCC.